In our last lecture, we discussed about the sodium abnormalities, specifically hyponatremia. Now, in this lecture, we are going to move on to the other spectrum. What happens when the sodium value goes up, or hypernatremia? This is a continuation of our discussion on fluid and electrolyte balances, and today we are going to complete sodium abnormalities. All right. Hypernatremia, as the word implies itself, hypernatremia means that excess of sodium or increase in the sodium plasma concentration categorically greater than 145 millimoles. Now, hypernatremia as compared to hyponatremia is considerably less common and slightly less complicated. In hyponatremia, we had a lot of things to look at, specifically in terms of the osmolality and then the urine volume. Hypernatremia is considerably less complicated, but it is very dangerous. It has a lot of mortality of about 40 to 60%. So it is very important whenever we have someone with hypernatremia to find out what is causing hypernatremia, because in the long run, it can cause a lot of trouble for us. So as I just defined, hypernatremia is excess of the sodium concentration. Categorically, it is defined as greater than 145 milliequivalents. What happens now with hypernatremia is as the extracellular fluid or the plasma specifically is hyperosmotic or hypertonic. This draws water out of the cells. Now, as we saw in hyponatremia, when the extracellular fluid or the plasma is expanded, the water moved by following the rule of osmosis from outside the cells to inside of cells. In hypernatremia, the opposite happens. When extracellular fluid or plasma becomes concentrated, the intracellular fluid water volume is greater than the extracellular fluid volume. So water moves from intracellular fluid compartment to the extracellular fluid. This leads to the shrinkage of cells. And this shrinkage of cells leads to all the abnormalities. This is specifically very evident in the neurological system. And as with hyponatremia, the major manifestations of hypernatremia will also be evident in the neurological system. This is a schematic diagram showing you what happens with hypernatremia. As you can see that with the greater extracellular fluid osmolality, water will try to move from the intracellular compartment to the outside of the cell. Now this happens generally when the sodium concentration is above 145 to 150 milliequivalents per liter. And as I just told you, cells shrinks as the water is pulled out into the extracellular fluid compartment. This shrinkage of the cell can lead to a lot of problems. It can lead to, in the neurological department, as we are going to see in the clinical features, it can lead to confusion and various bleeding abnormalities in the brain. Along with that, if it stays for a long time, it can also lead to seizures and coma. Now, what happens with hypernatremia to the body? What are the effects on the body? This is again a schematic diagram explaining the previous point which we just discussed. With the movement of the fluid from the intracellular compartment to the extracellular compartment, the cells shrink, and this leads to dehydration at the level of the cells. The water will move out from the cells to the extracellular fluid compartment, which comprises the interstitial fluid and the plasma. This movement of water is because of the increase in the sodium concentration in the plasma. Sodium is more concentrated relative to the water. What can cause this? There are various causes which we are going to discuss in the coming slides. But you can think of sodium abnormalities just as I told you in the lecture on hyponatremia. Consider the sodium abnormalities as the abnormalities of water. The sodium itself is very rarely, sodium abnormalities by itself are very rare. Instead, it is the movement of water either from out of the body or inside the body that can lead to variable sodium concentration. So whenever there is hypernatremia, it means that we have an excess of sodium in terms of water. So any abnormality that can lead to the loss of free water or water which is free of electrolytes, or a diuresis, for example, in which water is lost along with some other solutes like glucose or mannitol, and there is relative conservation of the sodium loss, or the sodium level remains the same. This can lead to hypernatremia or increase in the hypertonicity of the plasma. If it happens acutely, it can lead to a lot of symptoms, just as in acute hypernatremia. But if this happens slowly, for example, it takes greater than 48 hours, then the body cells, specifically the neurons, or the brain cells, they can adapt. They can and to adapt for the dehydration, they can move the osmolytes or variable solutes like glucose or other things into the cells to compensate for that acute loss of water. This leads to generally a normalization of the fluid concentration, and this is very important for the skin, muscles, bones, and the other tissues. Sodium and water can be lost by a lot of processes. As you know, kidneys are the major sources, the renal losses are the major ones, but apart from them, there can be some insensible losses, like the water can evaporate from your sweat, or they can be evaporate from your respiratory system via ventilation, and along with the GI tract, there might be some GI tract losses that can cause all these problems. We are going to discuss these in detail in the coming slides. Now, continuing our discussion on the effects of hypernatremia on the body, what happens when there is increased plasma sodium concentration, or for that matter, increased osmolality? For example, normal osmolality, is about 280 milliosmoles per kg of water. If the osmolality goes above 290 or 295, what happens? There will be decreased left ventricular contractility. As you know, there is a sodium calcium pump in the myocytes that regulates the movement of the sodium in and out of cells and the movement of the calcium. So for that pump to work, there has to be a normal osmolality. If there is hypernatremia or hyperosmolality, that pump will be disturbed, and the pump won't be able to get sodium out of the myocytes against this concentration, and this will lead to a decrease in the calcium movement inside the cells. And with the decreased calcium concentration inside the cells, there will be decreased contractility. As you know, calcium is needed for the contractility of the myocytes. So this will lead to decreased left ventricular contractility, and this can lead to all the signs and symptoms which we studied in shock, hypovolemia. It can lead to hypertension, tachycardia, compensatory tachycardia, and then a whole plethora of symptoms by the activation of the renin-angiotensin system. If this decreased left ventricular contractility is very long term, or it is very greater in extent. Similarly, we can have pulmonary edema, which can lead to hyperventilation. This hyperventilation can lead to acid-base abnormalities. We can have a disturbance in the glucose utilization by the cells. There will be a decrease or impaired gluconeogenesis. We might have some glucose abnormalities. We have to check for them. This happens when there is very long-standing or very acutely increase in hypernatremia. For example, if sodium concentration is greater than 150 milliequivalents per liter, then that is a very dangerous condition where all of these abnormalities can develop. Similarly, we can, because of the increase in the osmolarity, we might have some muscle membrane breakdown, which can lead to rhabdomyolysis or cramps in the body. And if these symptoms continue, specifically in the context of the nervous system, the patient can develop restlessness, coma, obtundation, and this cerebral shrinkage. As the water moves out of the neurons, the cells shrink, and this can lead to a risk of the vascular rupture. We might have subdural hematomas or subarachnoid hemorrhages in this patient. So these are the generalized effects on the body of increased osmolarity, specifically if the osmolarity or the sodium concentration is very much higher, greater than 150 milliequivalents per liter. All right. Now let's discuss a few causes of hypernatremia. What can be the various ways in which a person can acquire hypernatremia? Hypernatremia, as I just told you, is more of a water loss compared to the sodium loss. So what can be the loss? What can be the pathways through which water can be lost? They can be either the renal causes or the renal loss of water, or the non-renal causes. Let's just discuss at the level of the kidney what can go wrong for us to develop this hypernatremia. Now, if there is an osmotic diuresis secondary to, for example, hyperglycemia, like someone who has uncontrolled diabetes mellitus, or someone who is having a diabetic ketoacidosis, if someone is having uremia and there is excess of urea in the plasma, and if there is some obstruction which can lead to long-standing obstruction, and if we relieve that obstruction, there can be a post-obstructive diuresis. Now, in all these conditions, there are solutes in excess of sodium which are being lost along with the water. For example, in hyperglycemia, there is an excess loss of sugar. In excess urea, there is an increased loss of urea. Sodium concentration relatively remains same if we talk about the relative concentration, but because of the loss of water along with these solutes, the plasma becomes concentrated and sodium concentration is the one which is going to increase. And if you remember the plasma osmolality equation, it involves the three factors: sodium, glucose, and urea. So if the others are disrupted, the sodium tries to equilibrate that. But because of the loss of water along with these solutes, the plasma becomes concentrated. Similarly, if we give mannitol to someone, as we know, mannitol is an osmotic diuretic, then it also leads to this hypernatremia if it is in a lot of excess. Now, apart from the osmotic diuresis, there can be some ADH abnormalities like central or nephrogenic diabetes insipidus. In central diabetes insipidus, we know that there is a problem in ADH secretion, and this can lead to difficulty in conserving the water, and the water loss will be greater, for example, and there will be a lot of dilute urine. The urine osmolarity will be very low, and this free water loss leads to the concentration of the plasma. Now, if it happens at the level of the pituitary, and there are some abnormalities, for example, some trauma, some granulomatous disease, or destruction of the pituitary by any tumor or metastasis of the tumor, there can be a lot of causes. Then this is termed as central diabetes insipidus. The other one is the nephrogenic diabetes insipidus, in which the ADH secretion is normal by the body. Pituitary is working fine, but there is some abnormality at the level of the kidney. Be it because of some drugs, for example, like lithium or ifosfamide, or because of some tubular injury like the acute tubular necrosis or tubular interstitial disease, which can lead to this nephrogenic diabetes insipidus. There can be a few genetic abnormalities as well that interfere with the aquaporin expression on the collecting duct, and as we know, these are the V2 receptors of the ADH. The V2 receptors can be disrupted, or there can be a problem in the insertion of the aquaporins, which are required to absorb free water. So these genetic abnormalities can be there, or because of some drugs or any problem in the kidney level. We're going to rule them out step by step if we think that nephrogenic diabetes is the problem. And in nephrogenic diabetes, the ADH level is primarily normal, but there is a similar problem that there is loss of free water or dilute urine. We are going to discuss it in detail in the coming slides. How do we differentiate them through our labs in the patients? Now, there can also be a rare abnormality, especially in the pregnant females, which is termed as gestational diabetes insipidus. We are going to discuss it in the coming slide. How does this happen? Explaining the renal causes with the help of a diagram again. Now, just as we talked about central diabetes insipidus, if there is destruction of the neurohypophyseal neurons, or there is some mutation in the ABP or the ADH secretion, this happens at the level of the pituitary or at the level of the supraoptic nucleus of the hypothalamus. Posterior pituitary is the one which is majorly affected, and for example, if there is some panhypopituitarism that affects it, or if, as I just talked about, there is some tumor invagulation or metastatic tumor are the more common, or some brain injury or some brain surgery recently which disturbs the ADH levels. This leads to decreased ADH production in the body. Similarly, if someone is drinking a lot of water, now if someone is drinking free water, that leads to dilution of the sodium. As we discussed, the primary polydipsia is the one which affects the sodium concentration and leads to hypernatremia. But if someone is consuming excess of salt and water, like someone, if someone is consuming hypertonic water in which the solute concentration is greater, or excess of the sodium bicarb, if we are giving someone IV sodium bicarb or IV sodium chloride, which is hypertonic than the plasma, that can lead to an increase in the tonicity of the plasma as well. Now, what happens with all of these is that there is a decrease in the pituitary AVP release. Afterwards, what happens at the level of the kidneys is, if there is renal resistance to the serum plasma concentration, serum AVP or ADH, then that is termed as nephrogenic diabetes. In nephrogenic diabetes, the ADH level is primarily normal, but there is decreased response at the level of the kidneys. And this decreased response is either because of some phenomena because we are taking certain drugs, or because of some kidney injury, or either can be a mutation or a genetic problem. All of this leads to decreased free water absorption and an increase of the free water loss, solute free water diuresis. Now we just mentioned gestational diabetes insipidus. What happens in certain females is the placenta secretes a vasopressinase or a protease which leads to the cleavage of the ADH, and it takes care of whatever the ADH body is making. It leaves that ADH so that it is not able to perform its job at the level of the kidney. And this essentially leads to a condition similar to the diabetes insipidus, but this is reserved specifically for the gestational population or the pregnant female population. After the delivery, the body, with the help of when the level of this protease goes down after the separation of the placenta, the patient becomes primarily normal. But as long as as long as the pregnancy is there, if this is troublesome for the patient and leads to a hypernatremia in the female, then we might have to give them some ADH in the form of desmopressin or DDAVP, which we say. And the protease doesn't act on the DDAVP, and that person can essentially then control his osmolality. So this is the explanation of the renal causes diagrammatically. And as I just told you, in the gestational diabetes insipidus, there is a greater degradation of the AVP or the ADH. Now let's move out of the kidneys and let's see if a person's kidneys are perfectly working fine and he's able to dilute or concentrate the urine. What can be the non-renal causes of hypernatremia? They are primarily mostly similar to the causes of hyponatremia, but in this case, there is an excess of water loss as compared to the sodium. So in fever, when we know where body temperature is raised, we start sweating profusely. Sweat is essentially hypotonic. It has a lot of water as compared to sodium. So if someone is profusely sweating, for example, running a marathon or after a very heavy exercise, and they do not adequately rehydrate themselves, that can lead to excess of the water loss compared to the sodium loss, and essentially can lead to hypertonicity or hyperosmolarity or the hypernatremia. The sodium can become excessively concentrated. So after, someone with for someone with high-grade fever or a very strenuous exercise, or someone who has run a marathon, or someone who has been exposed to the heat for a long time, like someone who has developed heat stroke or heat exhaustion, or someone who has run a marathon in a very excruciating heat and has not adequately reperfused himself, that he can go into a lot of loss of water in excess of the sodium, and it can lead to hyponatremia. Similarly, if there are severe burns, that can lead to loss of excess water. Mechanical ventilation, specifically if it is very long term or very excessive, it can lead to insensible losses from the respiratory system. And then diarrhea, specifically osmotic diarrhea or viral gastroenteritis. This can lead to a loss of excess of the water as compared to salt. If there is secretory diarrhea, then that has a lot of solutes, and then that essentially doesn't lead to hypernatremia. That can lead to hypovolemia or hyponatremia. So you have to remember that osmotic diarrhea or the viral gastroenteritis, that are the major causes of hypernatremia. Secretory diarrhea doesn't cause hypernatremia. So this differentiation is important at the level of the GI. So the major causes of the non-renal causes are the GI causes and the insensible losses, either in the form of sweating or the loss of water from the respiratory system. And these are the ones which we are going to work on when we are going to rule out or have a diagnostic approach to evaluating the hypernatremia. Now let's look at the clinical features of hypernatremia. As with hyponatremia, with sodium losses, you have to remember two things. Number one is water is the major thing that can cause a sodium problem. And number two, the major manifestation of the sodium abnormalities are at the level of the brain. So whenever you're thinking about sodium, think about brain. When we are going to discuss potassium, the major manifestations of potassium are at the level of the heart or the skeletal muscles. So this demarcation is important to remember in your studies as a medical student, and also whenever you're going to practice and on the wards, specifically the medical wards. these abnormalities of the electrolytes, whenever you encounter a patient with sodium abnormalities, you should think about the brain and what can go wrong with these patients. So at the level of the brain, what happens is when the water is moved out of the cells, it leads to the shrinkage of the neurons. And this can present, if it happens in less than 48 hours, then this becomes an acute problem, and we have to quickly correct the sodium concentration so that the patient doesn't develop certain abnormalities. But mostly it happens chronically or greater than the 48 hours, and we have a fair window or time to act. So what happens is the patient can present with altered mental status, confusion, or headaches, and patient might be lethargic. And if it goes on for the long time, and the patient might develop deep coma. The one important thing to understand is with the shrinkage of the cells, there can be a damage to the adjoining vessels. And this can present in the form of parenchymal or subarachnoid hemorrhages. This is specific for the hypernatremia. This doesn't happen in hyponatremia. These symptoms can be a manifestation of hyponatremia, and you have to rule out the sodium abnormalities. So these are the symptoms which are common to both hyponatremia as well as hypernatremia. But the parenchymal or the subarachnoid hemorrhages majorly happen in someone who has greater sodium concentration. And similarly, subdural hematomas can develop. And one important thing is hypernatremic rhabdomyolysis. As we know that when the cells start shrinkage, the membrane becomes unstable. And with this instability of the membrane, there might be some membrane damage, and that can lead to rhabdomyolysis or muscle breakdown. And this can lead to increased potassium in the body. So all of these things are interconnected. The major manifestations are the similar. It might start as a headache or a confusion, lethargy, and this might progress to these bleeding abnormalities. In someone who has chronic or hypernatremia, or someone on which the symptoms have been present for a long time, these can lead to eventually severe neurological compromise. And the other problem that can develop is when the brain starts adapting and leads to increased movement of the osmolytes inside the cells to compensate for the shrinkage. If we overcompensate and overtreat those patients, if we give them a lot of water in return to compensate for this hypernatremia, we can overly correct and lead to a clinical hyponatremia. Like just as in hyponatremia, we discussed that with overcorrection, the patient can develop osmotic demyelination syndrome. In these patients with overcorrection, if we give them a lot of fluids in excess of the solute, we can overcorrect and essentially convert the hypernatremia into a hyponatremic state. And in hyponatremia, as you know, the brain can swell because of cerebral edema. So it is very important to time the correction and look at the timing of the correction, because generally it is recommended that you do not overcorrect by greater than 10 millimoles per day. So if someone, for example, is having 150 milliequivalents per liter plasma sodium concentration, so our target is to decrease that plasma concentration not greater than or less than 140 milliequivalents per liter in one day, because if you overcorrect it, then that can lead to cerebral edema. And with cerebral edema, as we discussed in hyponatremia, it is very difficult and dangerous, because the patient can develop seizures and coma, and it can also lead to the patient's death. So this is very important in the context of hyponatremia as well as in hypernatremia, to do not overcorrect, and we have to manage the concentration very slowly according to the guidelines. All right. Now let's look at our diagnostic approach, how we are going to rule out the various abnormalities, what are the important labs we have to consider talking about in the context of hypernatremia. Number one thing which we have to evaluate is whether the patient has, because of hypernatremia and increased in the plasma osmolality, what we expect is the increase in the ADH release. The ADH should be released, the thirst mechanism should be active, and the patient should be feeling thirsty and should be feeling a necessity to increase his or her water intake. But if we have to look at whether there are certain abnormalities, if there is an absence of thirst when there should be an increased thirst, then this might be a problem at the level of the osmoreceptors in the brain. And then we have to evaluate whether there are certain whether there are any tumors in the brain or any abnormality which are hindering the patient's osmoreceptors and not leading to an adequate response of the thirst and the ADH. So specifically in the context of the older population, we have to evaluate the thirst and the history of thirst and polyuria. These are the two things which we evaluate. The polyuria will give us an indication that the ADH is not working, and an absence of thirst will give us an indication that the osmoreceptors are the ones which are damaged in this patient. And then we do various investigations to look at what is wrong. Detailed neurological examination is very important because I just told you the sodium abnormalities primarily affect the brain. So just as in hyponatremia, in hypernatremia, we have to look at what are the various neurological profile of the patient. We have to look at the reflexes. We have to do a mini mental state examination. And all of these is very important to look at that what up to either evaluate the extent of the neurological problem or whether there is any problem in the neurological system or not. Polyuria evaluates the ADH level, as I just told you. And it is very important to have a good charting or good estimate of the daily urine output and the daily intake of the patient, because the patients with hypernatremia have an excess of salt solute in as relative to the water. So we have to look at the daily urine output, what is the concentration of the urine. We have to have an assessment of the extracellular fluid volume, whether the patient is hypervolemic or the patient is normovolemic, because the assessments will differ in both of these patients. Daily fluid intake and outtake is very important to assess. And then specifically in the context of diarrhea, diarrhea is the major non-renal cause of hypernatremia. Someone who is having diarrhea, we have to look at the volume of the diarrhea and the chronicity of the diarrhea, and then evaluate and treat that effectively or adequately. Let's look at the diagnostic approach. What are the various labs which are very important, which will help us in evaluating the patient? Three things are very important. Number one is the serum osmolality. This will give us an indication of how much the patient is hyperosmolar or how much the patient is hypertonic. And urine osmolality will give us a very good indication of what is wrong with the patient. Either the kidneys are working fine or the kidneys have some problems. And similarly, urine electrolytes will give us a very good idea of the kidney's performance and also will help us in calculating the free water deficit, which is important in the treatment of hypernatremia. Now, this flowchart is important and I want you to pay attention here. This is how we approach a patient of hypernatremia. The first thing to evaluate is the extracellular fluid volume. Either the extracellular fluid volume is increased or not increased. This is evaluated clinically. If the patient is having if the patient essentially is wet, if the patient is having edema or increased JVP, and if there is some ascites or anything like that, you generally see that the patient might have pitting edema. So if there is an increase in the extracellular fluid volume, that means that the patient has been administered excess of hypertonic sodium chloride or sodium bicarb. This is a very rare thing to happen because this is iatrogenic essentially. This can happen only in the hospital, that you have given someone excess of the hypertonic saline or hypertonic bicarb, and this is a rare commodity. But this is what happens if there is increase in the extracellular fluid volume. So you first have to rule out this thing. If the extracellular fluid volume is not increased, then we have to look at whether the kidneys are working fine or not, or whether the losses are renal or non-renal. What we should expect in someone whose kidneys are working perfectly fine is that the kidneys will be able to conserve water, and there will be minimum volume loss with maximally concentrated urine. That the ADH will be increased, and ADH will lead to conservation of water, and this will lead to a minimum volume of maximally concentrated urine. Now, if this happens, that means that the kidneys are working fine, and the loss of the fluid is extrarenal. This can be an either insensible water loss, for example, in someone with fever or strenuous exercise or mechanical ventilation, or the loss is either from the GI tract in the form of diarrhea, vomiting, etc. And there can be some remote renal water losses which are insignificant. So I just want you to remember that if the kidneys are working fine, then there is some GI loss or there is some insensible water loss. But if this does not happen and we have a we don't have the normal urine concentration ability, then we have to look at the urine osmoles. Now, if the excretion rate is high, for example, if someone is having polyuria, the volume is increased and the osmolarity is increased as well, greater than around 750 milliosmoles per day, then that is majorly because of some diuretic. Because this is because you are causing that problem, either because the patient is being given some diuretic like thiazide or loops, or someone like is having osmotic diuresis, either with the help of mannitol, or just as we talked about, the patient can have hyperglycemia or hyperuricemia, and this is the problem at the level of the kidneys. So this because the hyperglycemia, or if someone is having hyperuricemia, that means hyperuremia, that means that either there is some abnormality with the kidney and the kidneys are not able to get rid of the urea, or if someone is hyperglycemic or someone who has diabetic ketoacidosis, then that overwhelms the ability of the kidney to absorb glucose. Now, if that is not the case and we are having polyuria, and the concentration of the urine is very high, if there is very decreased ability of the ADHs, if ADH is not being secreted, or if ADH is not being able to effect on the kidney, then that will lead to an excess of polyuria. That will lead to polyuria and a dilute urine. The concentration of the urine will be low, or the osmolarity will be low. That contradicts our expectation that we should have a concentrated urine. But if we have a dilute urine along with the polyuria, there are three things. If we have a very low volume of the urine and the urine concentration is fine, then that means that the kidney, the problem is extra-renal. In the renal problem, we have to look at the urine osmolarity, because polyuria will be there in both the conditions. Now, if someone is having polyuria but the urine osmolarity is high, that means that there are certain other things along with the water and sodium, that there are certain osmotic diuresis or diuretics. But if there is polyuria and along with dilute urine, then the problem is with ADH, that ADH is not able to conserve free water. How can we differentiate the two causes of ADH, that whether it is a central cause of ADH or a nephrogenic cause? There are two ways. Number one thing is we are going to measure the ADH levels in the plasma. In someone with central diabetes insipidus, the ADH will be low. The ADH is unable to be secreted. But in someone with nephrogenic diabetes insipidus who is having a problem at the level of the kidney, the ADH level might be normal, high normal, low normal. It might be variable. So that doesn't give us a perfect indication of what is the issue. So we have to calculate the osmolarity and then give the patient ADH or desmopressin. And we have to then look at the response of the patient. If someone is being given ADH, first we calculate the urine osmolarity, and afterwards then we give the patient ADH. If the urine osmolarity increases after administration of the ADH, that means that the patient was deficient in the ADH, and that is because of central diabetes insipidus, that the ADH was not present in the plasma, and when you have given the ADH, the kidneys have been working fine and the person is able to conserve free water. But if the urine osmolarity increase is negligible or it remains unchanged, then that means that there is problem at the level of the kidneys. It is nephrogenic diabetes insipidus. And then you have to look at the drug history, whether the patient is taking a certain drug that is damaging the kidney, or if there is any abnormality in the kidney like interstitial nephritis or tubular necrosis that is damaging the tubules and hindering their ability to conserve free water. So this is a very neat diagnostic approach in the evaluation of the hypernatremia, and we step by step rule out the various causes, whether they are extrarenal or the renal. All right, let's look at how we are going to treat hypernatremia. Now, essentially, the person is water deficient. So what we have to do is give the patient water. The preferred route is the per oral route, or with the help of a nasogastric tube. We give the patient water if he is able to take it orally, or with the help of an NG tube. If someone who is not able to take the water orally, then we give them the IV either dextrose water or the hypotonic saline to conserve the water loss, or to make up for the water deficit. Now, there are certain neat formulas which we have to just evaluate and see that how we are going to calculate the water deficit. we start off by estimating the total body water. This is about 50% of body weight in females and about 60% in men. Now then, after calculating this total body water, we put that in this equation, that sodium minus 140 divided by 140 multiplied by the total body water. This will give us a water deficit, and we have to administer this deficit slowly over 48 to 72 hours without decrease in the plasma sodium concentration by greater than 10 millimoles per 24 hours. This is an important thing, because if we overcorrect or give the patient water very fast, then there is a chance of developing cerebral edema. Similarly, we also have to calculate the free water clearance. This is the formula which I also told you in the lecture on hypernatremia. We calculate the free water clearance by this formula. The V stands for the urinary volume, UNA stands for the urinary sodium concentration, and UK stands for the urinary potassium concentration. This PNA stands for the plasma sodium concentration. So this electrolyte concentration of both the urine and the plasma is very important to evaluate the free water clearance. And then we combine these two calculations on water deficit, and then we also look at the ongoing water losses, specifically the insensible water losses. We correct in about 10 milliliter per kg per day for the insensible water losses. This can be less if the patient is ventilated and more if the patient has high fever or hyperthermia. So we adjust for these insensible losses, and then we collect, based on these, we calculate the water deficit, the total water deficit. And after that, we correct this water deficit slowly over a period of 48 to 72 hours, majorly avoiding that correction by greater than 10 millimoles per day, as I just told you in the last slide. This calculation is a complex calculation which won't be required at your level in the undergraduate studies, but when you are going to work in wards, you will be requiring this equation and this calculation to calculate the free water loss total, and then compensated, corrected by not greater than by 10 millimoles per day. So this is how we are going to calculate the free water deficit and how we are going to correct it. Now, in addition to the free water loss, if we have the certain causes which we are evident, for example, if the patient is having diabetes insipidus, or if there is some osmotic diuresis, for example, in DKA patient, then in addition to the correction of the water, it is very important to correct for the cause. So in terms of the cause-specific treatment, if the patient is having diabetes insipidus, then we have to first evaluate whether it is central or nephrogenic diabetes insipidus. In the context of central diabetes insipidus, as you know, there is an ADH deficiency. The pituitaries are unable to produce ADH. So the correction for that is ADH in the form of desmopressin or DDAVP. We either give it to the patient intranasally, orally, or in the form of IV form. Now, if the deficit is at the level of the kidneys and the patient is having nephrogenic diabetes insipidus, then in these patients, you know that ADH levels are adequate, and we don't have to replace the ADH. In this context, we have to look at what is causing this nephrogenic diabetes insipidus. If there are certain drugs like lithium or ifosfamide or certain other abnormalities, then we have to get rid of the drug first. And then specifically in the case of lithium, because it damages the cortical collecting tubules, the ENaC channels, and at which the aldosterone also acts, we can counteract the effect of the lithium by, number one, by increasing the water intake. This increased water intake is relevant to all the forms of correction of hypernatremia, whether they are cause specific or we do that with the help of water correction, as we just mentioned in the previous slide. But specifically, we can give amyloride, which acts at the level of the ENaC channels and can counteract the effects of the lithium-induced nephrogenic diabetes insipidus. Now, along with this, another cause of nephrogenic diabetes insipidus, majorly the increased water intake will overcome that trouble to a lot of extent. But if there is still certain water deficit, then we can give thiazide diuretics to increase the diuresis and induce hypovolemia, which can in turn leads to increased water reabsorption at the level of the proximal convoluted tubules. So amyloride, thiazide, and in certain conditions, we might have to give patients NSAIDs or non-steroidal anti-inflammatory drugs to counteract the nephrogenic diabetes insipidus. So in the context of nephrogenic diabetes insipidus, I want you to remember all these steps that we initially increase the patient's water intake. Then if that doesn't work, we can give amyloride, specifically in terms of lithium-induced nephrogenic diabetes insipidus. Thiazides and NSAIDs can also be effective. But in the terms of NSAIDs, we have to look at their gastric toxicity or the potency of causing renal toxicity. And also it is very important to remember that these treatment modalities will help in the management of the chronic conditions, not in the acute management. In the acute management, our major priority is to replace the water losses as quickly as we can. Similarly, just as we talked about gestational diabetes insipidus in a female in which there is a protease secreted by placenta called vasopressinase that cleaves the ADH, and the patient is essentially in a diabetes insipidus state, we again correct it by increasing the water intake and giving the patient DD, AVP or desmopressin. Now, if the problem of hypernatremia arises because of osmotic abnormalities like osmotic diuresis, then in those conditions, especially, we have to get rid of the solutes that are causing. For example, if this osmotic diuresis is because of hyperglycemia, then we can make the patient normoglycemic. We correct the plasma glucose concentration. If the patient is having DKA or diabetic ketoacidosis, we get rid of the ketones. We give the patient insulin. We give the patient fluids. We correct the potassium. And if someone is having hyperuremia, then in those conditions, dialysis can be effective to get rid of the excess of urea in those patients, specifically if it is in the context of chronic kidney disease or acute renal failure. And if someone is taking diuretics or like mannitol or other certain diuretics that are leading to excess of water and solute loss, but the solutes are in excess of sodium, then those can be corrected by either stopping the offending agent and then correcting the water loss by giving the patient water and increasing the water intake. So this gives us a very good indication of the cause-specific treatment of hypernatremia. All right. This concludes our discussion of the fluid and electrolyte balances about sodium. Initially, in the first part of the lecture, we talked about hyponatremia in great detail, what causes hyponatremia, what are the various abnormalities, how do we correct it with the help of osmolality calculations and volume calculations. And in this part, we discussed in great details hypernatremia, what are the various causes, what are its effects on the body, and how do we approach diagnostically, what are the various markers in the plasma and urine that are going to help us in evaluating the patient with hypernatremia. And in the last part, in the treatment section, we discussed how do we calculate the water deficit and how do we replace it slowly so that we don't overcorrect it, and what are the various cause-specific treatments, modalities that we have to overcome the patient hyponatremia or to essentially correct the plasma osmolality. Thank you for watching this lecture. Thank you for watching sqadia.com, and I'll see you in another lecture.